Please welcome to the stage Greg Jungles, Moses Ike, Dr. Jesse Goodwin, and Chris Lee.
Good afternoon, everybody. Thank you for joining us today. I hope you all are still wide awake and ready for a really engaging conversation. I am Greg Jungles. I'm the health tech practice area lead at the Advanced Technology Development Center out of Georgia Tech. I'm your moderator today and look forward to this conversation about how innovation is changing the face of healthcare delivery. From hyper-accelerated pace of AI to an evolving regulatory and funding climate to post-pandemic social shifts, it's clear that innovation is going to be a key path to changing how healthcare is delivered. And in today's session, we are going to take the time to discuss that. I'd like to start by introducing our distinguished panelists. Moses Ike. Moses EK serves as principal and on the venture team for Catalyst by Wellstar. He draws on over a decade of experience as an investment and financial executive within a variety of healthcare organizations. Moses specializes in early-stage health tech and service startups and has led a few companies from seed stage to exit as both as an investor and as an operator. Welcome.
Thank you.
Jesse Goodwin serves as Chief Innovation Officer at the Medical University of South Carolina. Jesse spent more than a decade engaged in innovation across a broad range of medical therapies with applications in academia and industry. Jesse has previously served as Vice President of Development for the Zucker Institute of Applied Neurosciences and served as the Deputy Director for the MUSC Foundation for Research Development, the university's technology transfer office. Prior to joining MUSC, Jesse was the Director of Medical Device Practice of a Boston-based intellectual property consulting firm and received her PhD in biomedical engineering from Stony Brook University and completed a postdoctorate fellowship with the Harvard MIT Health Sciences and Technology program. Chris Lee is the Chairman and CEO and co-founder of Huxley Medical Incorporated. Huxley is a growth-stage med tech company developing diagnostic solutions that streamline access to care for over 1 billion people living with sleep and heart disorders. Chris is a serial entrepreneur, serving as founder, advisor, or individual investor in over a dozen healthcare and technology startups. These businesses have so far improved the lives of over 100,000 patients worldwide and netted over $250 million in shareholder returns. Chris volunteers in several boards to promote STEM education, translational research, and social impact. Panelists, welcome. I would like to start by having each of you provide a brief description of your organizations and what your role in those organizations is. If you can, also please share a major trend that you're seeing in healthcare innovation today. Moses, you want to start?
Sure. Happy to go first. Thank you for that introduction. So like you mentioned, my name is Moses EK. I'm a principal on the venture team within Catalyst by Wellstar. So Wellstar is the largest health system in Georgia. We have 11 hospitals and I think maybe 30,000 employees throughout the state and beyond. And so Catalyst kind of serves as the transformation and innovation engine inside of Wellstar, where we kind of have this three-pronged approach that we take towards innovation. And I think kind of one leg of the stool is venture investing, where we will make direct investments in pre-seed to Series A kind of companies. And I think over the last 2 years, we've made at least 24 direct investments. I think the second leg of the stool is our lab function, where we will innovate, pilot, and scale kind of within our health system. And after successful pilots, we can scale it throughout the entire ecosystem. And so I think we've done 12 enterprise contracts and over 24 pilots throughout the health system. Final leg of the stool, our studio function, where we will actually create companies from the ground up and kind of help spin them out and find an executive team. And I think to date, we've done 2 companies so far. So that's my role within the organization. In terms of a trend within innovation that we're tracking and excited about, just at a very high level, we're tracking AI helping doctors catch things earlier. purely put, whether that's spotting signs of cancer in a scan or, flagging patients who may be at risk for sort of complications. I think we're tracking some of those trends that are going towards making care more proactive instead of just reactive. So that's our space.
Thanks.
Yeah, so I'm Jessie Goodwin. I have the great pleasure of serving as the Chief Innovation Officer for MUSC, as we call it. We don't call it Musk. We do call it MUSC. We are headquartered in Charleston, South Carolina, but we actually have 17 hospitals across the state and many ambulatory and clinical sites. I have obligations to both our health system as well as our university side. So I spend my days dividing up my time across our tripartite mission, looking at how can we innovate in clinical care, how can we innovate in the educational sphere and really arm our student learners as well as our primary didactic faculty members, as well as supporting our research infrastructure. So kind of a broad scope of work there. On a tactical level, I do a lot of programmatic and ecosystem building to support entrepreneurship, both within the organization and as well as the region, but also looking at how can we facilitate a culture of intrapreneurship such that the people who work within the organization feel empowered and compelled to solve pain points for themselves within their sphere of influence. And I'm looking forward to today's conversation. One trend that I see as it pertains particularly to academic systems and academic centers is, and I'll tackle it from the life science side, is gone are the days when we can expect a pharmaceutical or diagnostic company to come in and just license our early stage data and our patents and take it and run with it. I think the role of startup companies is really, really important. It really is becoming the only pathway to broad success, particularly when you're talking about innovations coming out of an academic system. And so I think that the conversations that we've had today already about funding and sort of adoption and startup companies are really important to have, and I'm looking forward to continuing that now.
Thanks, Greg, for having me. Name is Chris Lee, Chairman and CEO of Huxley Medical. As Greg mentioned, serial entrepreneur. Basically, my sweet spot is solving really tough problems for really smart people and translating academic technologies from basically bench side all the way to patients. So of the dozen or so startups that I've been involved in at different levels, they've all had some academic or university type genesis, and that's spawned everywhere from diagnostics, which is what Huxley currently does today, all the way to some of my prior companies that were more in the therapeutic and medical device implant space. So in terms of the trend that I'm most excited about and kind of have really backed, it's really the type of work that we're doing at Huxley. So when we think about kind of the future of healthcare and where it's headed, there are obviously a lot of trends that we're super excited about. The main one that me personally motivates me, and I think we're starting to see this even with Wellstar Catalyst and some of the companies that they're funding and promoting, is really this whole direct-to-patient or remote care aspect. So I don't know how many of you watch Monday Night Football, but you're starting to see a lot of commercials from Eli Lilly about getting, your cancer therapies directly or getting the patient more involved in managing their healthcare. We really think that's where the market's headed and that's where healthcare is headed. And even though there's a lot of hype about software could do that, AI could do that, we really think fundamentally it needs multiple pillars to get that kind of what some of the panelists have mentioned earlier, and probably what we'll discuss a lot more during this session, so I don't want to take all the time now. I personally think, and Huxley, kind of the company that we're building, we see the three pillars really around hardware, so devices or sensors or technologies that are hard tech that really enable providers to do more with less. There's obviously the software. I'm sure we're going to talk a lot about that. But at the end of the day, healthcare is still a service industry. It's still a service provider. So services has to be a big part of that, right? And that's going to be tough to replace solely with hardware, software, therapy type solutions. That's human interaction, that's collaborations, that's a lot of things that we'll talk about this panel. So kind of that's where we think the trend is headed, and that's kind of the areas that we focus on as a company.
Great. Thank you guys so much for that. I'd like to start by probing how innovation is happening in your respective organizations. Moses, I think I'd like to start with you, and if you can share how your organization is cultivating and managing innovation, that'd be great.
Sure. So I touched on this a second ago, but we really start, again, with sort of our three-legged stool in terms of evaluating opportunities to innovate. And so whether it be sort of direct investing, whether it be kind of co-piloting and scaling throughout our health system, or building a new company sort of through our studio function, that's the process that we go through in terms of evaluating. I'll bring up an example of a company that we spun out and scaled, a company called VFlock, which is high-level at AI scheduling co-pilot that for our nursing team that lets them swap shifts and manage their schedules. And so it's through a sort of AI chatbot sort of entity called Swift. I almost got that wrong, Swift. And so this actually came about through just really intense diligence and conversations with our nursing team, where we found high turnover, high burnout, and through a lot of diligence, we just got to the root of it, and it was actually issues with scheduling and coordination that was causing a lot of this turnover. And so we ended up with I believe it was like just a 6-month pilot in one of our care sites, and through really meaningful sort of KPIs, OKRs, and results, we actually just were able to kind of scale it throughout all 11 of our sites throughout the healthcare system. So that's kind of an example of how through kind of grassroots conversations we evaluate an issue and then kind of spin it up and scale it system-wide.
Fabulous, thank you. Jesse, how about you?
Yeah, so innovation is, I think, the fabric of MUSC. I know it's a really buzzwordy word right now. It's in my title, and I always sort of smile at that. But it is, if you ever have the opportunity to speak to MUSC's president, Dr. David Cole, the one word that he'll mention most, he's really passionate about innovation as being part of our culture. It is the only word that shows up in the mission, vision, value statement for the organization. It's in all three. And we take it a step further. On the health system side, it's actually one of our pillars of excellence that we measure ourselves on an annual basis as part of our scorecard. It actually affects the pay-per performance for all of our care team members within our organization. So from a cultural standpoint, it really starts at the top as a philosophy and a belief that that's how the institution's going to move itself forward, and is embedded all the way down through the metrics by which we measure our performance. So how do we support that? Well, we've taken a really broad definition of it. We generally talk about innovation on campus as sort of creative solutions to pain points, because I found early on in my career that the word innovation didn't really mean much to people. They couldn't really define it. And it was really important to Dr. Cole that every person on our campus, or on all of our campuses, could envision themselves as an innovator. And so we wanted to make sure it wasn't just a white coat thing where it was our doctors and our PhDs, but anyone from facilities to parking management felt empowered to solve problems within their own sphere of influence. So within my sort of sphere of teams, we do have a tech commercialization office that manages intellectual properties and our startup companies. We have an on-campus incubator. We have a team within our health system that works with early stage companies looking to pilot within our systems, outside in. And we also run promotional challenges throughout the year where I have 600 leaders from across our organization who on an annual basis take a goal and do generally more process improvement type projects to solve pain points within their own sphere of influence. And those really range pretty broadly, but it's a really good way to get that cultural wheel turning to say, we know things aren't ideal. Let's empower you to make that change and see what we can do with it. Sometimes that may turn into a handoff to our tech commercialization office. Sometimes it may turn into a handoff to the team that does early stage pilots within our health system. And sometimes it's just something that we sponsor within their own unit. So we have this sort of widespread but fairly robust now sort of process to help support innovation within our ecosystem.
Great, thank you so much. So I'm going to run this one back to you, Jesse. What technologies have had the most impact on care delivery in your organization that you've seen?
Yeah, I think it would be hard to skip over AI of late. As I tell my team, it's AI every day, all day. But it really has made a profound effect in some regards, and you can kind of see, and this is just the beginning of that flywheel that's turning. And so last year, we actually rolled out Nuance DAX, which is an ambient listening technology, and we did it first for our clinic sites and then brought it inpatient. And the idea was to save pajama time, right? And so that in our pilot was embraced so broadly with such tremendous success by the providers who were using it that we've now offered a license to every provider across MUSC. So AI for sure is one, but the other one is telehealth. And I think we heard a lot about virtual care earlier. MUSC happens to be one of 2 centers of excellence in the nation for telehealth, so we were doing it way before COVID, and that's really just expanded. So we've put in virtual triage into our ERs. We're working on virtual nursing. We have a virtual sitting program, and so telehealth in that area has really sort of transformed our approach to care within our walls.
And so with those experiences and those observations, what is the general feedback or response you've received from staff and clinicians and everything else? Are you seeing a positive result?
Yeah, I mean, I think there's lots of data. We've all seen the charts in terms of adoption rates, right? There's always like the people who are really eager and going to raise their hand, and they are the first in line for their iPhone too, and then there's the laggards, and then most people fall somewhere in the middle, and I think that that's what we've seen culturally as well at our institution. I think what I can say is that a top-down approach where we just sort of like mandate that this is the technology that they're going to use has not worked well for increasing adoption rates. I think there has been good adoption, a little bit of apprehension, but what has worked better is getting that sort of boots on the ground champion who can be the colleague that's showing, and sort of you need that champion that's there, the user. Me coming in and being like, I found you a cool technology, and now you're going to use it, and I'm going to track your use is never a good strategy.
Right. Okay, great. And so Moses, tell me a little bit about your organization. What's the most impactful technology innovation that's affected care delivery for you all?
So we did not rehearse this, but also Microsoft DAX Nuance. Interestingly enough, so at Wellstar, we also started with a pilot and an instance of Microsoft DAX Copilot. If you guys are familiar, that's an ambient scribe that listens to patient-physician conversations and then automatically generates clinician notes in real time, integrates it into the EMR. And so to your point around physician time, the pain point for us that we identified was our physicians that said they weren't able to practice at the top of their license because they were spending significant time with administrative work and doing clinical notes. And even from a patient sort of satisfaction perspective, they kind of go into the doctor's office. The doctor never really kind of looks them eye to eye and has a conversation with them, kind of have their shoulders turned, typing on the computer the whole time. And so this was actually just a simple opportunity to transform the kind of patient-provider experience where it frees the doctor up to have extended time face-to-face with the patient. And so amazing sort of initial results in terms of patient satisfaction, provider satisfaction, and like I said, allowing the physicians to sort of practice at the top of their license and provide more meaningful care.
And this is not deep tech, so I mean, I think it's incredible that there are opportunities to really transform healthcare with some of the most simple applications of technology. So Chris, being on the other side of actually having product that you're selling to health systems, what's your observations in regard to health systems and physicians or practitioners being willing to adopt new technology at this point, especially with at the pace it's coming, and what are some of the hurdles that you face there?
Yeah, good question, Greg. And I think, as you all know, because healthcare, at the end of the day, it's a service industry, people's livelihoods and lives are at stake. You know, change is really tough, right? You have regulatory hurdles, you have compliance hurdles, you have workflow hurdles. It's going to be, and to sustain that level of care, it's going to be tough to manage change. So whenever we think about implementing change or change management, it does come down to, do we make it easier for the provider? Do we make it easier from the whole value chain all the way from procurement and pre-authorization of patients all the way to therapeutic outcomes and billing. So that's one of the things that we've seen is necessary to really institute true innovation. And I also think too, echoing what Jesse and Moses said about some of the things about like operating at the top of your license and how does innovation allow to do that. I think that's going to be super critical as we move forward, is that, physicians shouldn't, and healthcare providers in general shouldn't be focused on administrative tasks, logistic tasks, and the like. And then same thing as what you mentioned, Jesse, about culture and champions, continuing to foster that and finding that as an outside vendor going in. I think it does take a holistic approach, and it does take a system level and team effort to institute those. So hopefully that answered your question, Greg.
Absolutely, great, thank you. This is open to everybody, but what are your all thoughts in terms of how we can best implement change without drastically influencing or affecting the cost to consumers and patients? Quality is another aspect of that, so feel free to include that as part of the consideration.
I can start. So I think at Wellstar, we try to implement change without raising costs by targeting the waste and not care directly. And so I used the example before around VFlock, which was a company that we used to improve nurse scheduling. And so in that instance, instead of adding new layers to the workflow, our goal was to use AI to reduce the back and forth and fill shifts faster and eliminate a lot of the overtime. But the goal there is to not touch patient-facing services or raising spend. And so the goal is to kind of target the waste and not the care.
Great, thanks.
I think I would echo that. I mean, at the end of the day, candidly, most technology costs money. I mean, I think we heard in the CEO panel at the beginning that one of the CEOs said that he wished everyone would just go back to paper because it would be less expensive. He was joking, of course, but there's a truth to that, right? When Chris comes to pitch to someone like me at a health system, he's not offering the technology for free, and so there is a direct cost that's going to have to be managed within a health system. And so we do spend a lot of time trying to create pro formas for technology and measuring KPIs that are going to create value for the organization. I think where we as if you're part of a health system, where we have to be really mindful is that it shouldn't always be either on expense reduction or revenue capture. I think it's beholden to us to remember that there are other metrics, like can we decrease turnover, which doesn't show up directly on the balance sheet, but does have a cost associated with it. And so I think targeting, to Moses's point, some of the extraneous stuff or some of the waste within the system that may not actually even be direct dollars that we're going to capture on a balance sheet are ways that we can keep this system whole while bringing in new technology that we have to pay for without having to increase the cost to the patients and the people that we're caring for.
Great. Chris, do you have anything to add?
I think just to get a little bit more granular, so we did mention in terms of when you do look at a pro forma, what's the biggest cost drivers? It's facilities and people or payroll, right? So the idea is like the technology has to somehow get more out of less. And when we talk about operating on the top of your license, that's kind of how we at Huxley view it. It's like all this administrative stuff, all the logistics stuff, all the stuff that you didn't really go to med school or nursing school or just train to be a healthcare provider to be. It's like you shouldn't be doing that. It's like in order to get the most leverage out of you, you need to be operating there. So when we think about developing technologies and promoting it to healthcare systems and services, it's to be able to outsource that. And I think another touch point that we mentioned is this whole remote care. It's like anything that shouldn't be done in the facility and saving the facility for really high value, high revenue type of procedures, we should try to do that. We should shift those extraneous procedures outside of the clinic in the patient home and elsewhere. So kind of a little bit more granular thoughts in terms of where I think we could cut costs down.
Perfect. Thanks so much for all of you with those responses. I'd like to turn our attention to investment and scaling innovation. I'm going to start with Chris, so just hold on to your mic. What role does funding play in shaping the direction of healthcare innovation? And from your perspective, what are the hurdles for funding?
Yeah, obviously funding plays a huge role in kind of new technologies that get developed and adopted. And when we think about hurdles for fundraising, they're actually quite similar to the hurdles that it takes to get a product to market or to get establishment system-wide. So when we look at that, when you take a concept from idea bench or from a lab bench side to bedside, you have regulatory hurdles, you have reimbursement hurdles, you have compliance hurdles, and within compliance, you could say you have privacy and security and cybersecurity. You have, change management type hurdles. You have long sales cycle type hurdles. So there are a lot, and I think there's a reason why, people people in tech try to get into med tech and haven't really been successful, and vice versa. It's because of these hurdles. It's because, the culture of getting over those hurdles is very different in regulated industries such as healthcare versus tech. So I think in order to overcome those and where the funding goes, it really takes special types of investors, special types of financiers that understand that, hey, once you overcome these hurdles, you have a pretty compelling business, you have a pretty durable business, and at the end of the day, you're impacting lives for the better.
Excellent, thank you. Jesse, in your roles, there are so many different aspects that you're engaged with, from cultivating IP to commercializing IP to investing in IP to deploying technology into the health system. What's your perspective on this, and what are your thoughts in terms of the role of funding?
I think funding is critically important, like Chris said. In part, and I'll tackle this from a few different angles. In part because one of the ways to scale, right, it requires dollars, right? But it's a really interesting conundrum, particularly early on and at the stage of companies that Moses and I are typically dealing with. They're really early stage, and they need funding to get into a health system to actually prove the value, so that then they can go raise more money, right? So it's those first dollars, that first integration are really challenging, and they're the hardest to get, right? Because it's the riskiest money to put in because you have no idea if it's going to work or not. And within South Carolina, my home state, we're in the low 40s for venture capital deployment if you look at U.S. News and World Report. And so that early stage risk funding for life sciences or health tech it's even harder to get within the state. That valley of death that you've seen the graph of is real and true. It's like most early stage companies don't die because their technologies don't work. It's because they can't get those first dollars in. I had someone tell me it's much easier to raise a Series C than their pre-seed or their Series A, right? It's a conundrum. And so I think that can't be really understated, the role that funding plays in success. And I think it takes more than just one organization or more than one fund to solve that problem. But I think as a collective, particularly if we can look regionally, there's strength in numbers, because one of the things that I'm interested in is not having to have early stage companies leave the Southeast to be successful, right? Like, we know there's funding in Boston and we know there's funding on the West Coast, but we should be able to solve the problem here to keep the companies and the people here that we've trained and we've grown and that we've spun up. And so it's a real and true challenge. I think there's lots of efforts to be put towards it. And I think as a region, we should be sort of collating efforts together to solve it.
Moses, what are your thoughts?
No, just to echo those points, I think, all of the points that were made around healthcare's really unique and long sales cycles, and just the process of validating that there is a viable market for new technology, and that confirming that technology solves a problem that a healthcare system is willing to sort of pay for, I think is uniquely expensive. In addition to, I think, some of the incumbent pressures that are also taking place, where there are some more well-funded and more established sort of tech entities where if they kind of flip a switch and kind of offer your point solution, then in an instant that can totally sort of wipe out and change a market. And so lots of different variables to consider in terms of funding that goes into healthcare. But just to to echo what was said, that process of product market fit is probably the most important.
If I can add on, I think there's an interesting role for health systems. Moses and I work for fairly large ones, right? You have 11, I have 17 within ours. So we're pretty substantially sized, and I think that there's probably those of you in the audience who are working for sort of larger entities as well. We're not talking about the community hospitals. But I don't think the funding has to be direct dollars per se. Oftentimes it's that in-kind contribution that you can have by incubating an early stage company within our environments would be incredibly valuable, both for the organization and for the company. And that does correlate into sort of a direct, you can put a dollar sign to it. And so I think that there's a nimbleness and a creativity that I would encourage all of us to sort of lean into. I will say MUSC is trying. We're not great at it. We want to treat everybody like a Medtronic, and it's not the case. We're like, sure, we'll bring you in, and you could pay us sponsored research dollars, and it tends to be a traditional transaction, but we're leaning towards it. But I think there's a flexibility in terms of how we think about funding, where we could get more creative, particularly if you've got a little bit of scale and scope where you can absorb like that.
Perfect. Thank you. Perfect. Moses, you did mention something around validating market viability and the readiness of a new organization, a startup organization, to be able to be secure and productive and effective in your as you roll them out. Can you tell me a little bit, with your venture hat on, a little bit about the due diligence process, and what do you look for in startups that get you to a point where you're comfortable with them being a key part of your overall operations?
Yeah, so super high level, I think, number one, we're validating market fit by kind of starting with the budget line, right? So if our health system is already spending money on either workarounds, inefficiencies, or labor to solve a problem, that kind of validates that this is a real pain point and there's already a willingness to pay that's sort of been established. So basically, if there's no budget, there's no buy-in for the most part. Maybe a good example could be a startup that's focused on reducing avoidable imaging, for instance. So health systems like ours, we're typically already spending millions on duplicative scans, on radiation exposure, and prior authorization workflows and things like that. So that type of validation for us kind of proves that there's kind of product market fit there. So I think once a kind of health tech startup has demonstrated that they solve a painful, budgeted problem with some sort of urgency behind it, I think we then sort of evaluate a readiness to scale by a few things. Number one, do our frontline users love it? I think number two, as a buyer, do we need custom work to implement it? And what I mean by that is that sometimes at the early stage in product market fit for startups, they often require consulting style build-outs for each deployment. And that's often sort of evidence that they haven't kind of productized it yet. And it's not ready to be implemented at scale at multiple sort of users. And so I think that's another thing we look for. And lastly, just in terms of measuring outcomes, can we measure outcomes in less than 12 to 18 months via a pilot? I think the thinking behind that is that as a buyer, we typically want to see value between 90 to 180 days, and as opposed to sort of a year-long study. The idea being that these long, kind of vague pilots, they often become kind of like science experiments that never really get contracted into, kind of converted into full contracts. And so it depends. I mean, I think there are different circumstances go into sort of different products, but generally speaking, if you can sort of validate your outcomes in 90 to 180 days, those are some indications that it may be ready for scale.
Perfect. Thanks. Jesse, how about your organization?
Yeah, we look at a lot of the same things that Moses just mentioned, stage of development. We look at priority within our health system. Is it on the list of things that we're looking to address? Even if it is a pain point, where does it rank on that priority list? Is it something that's at the top or the bottom? Because that'll drive resource allocation. from the other side of the house, looking at sort of my university hat, I have a lot of faculty-led startups. At any point in time, we have somewhere between 60 and 70 startups in our sort of sphere. And so for them, we're looking at what's the stage of development, what type of data do they have, and we talk a lot about like the leadership team, right? Is it a faculty member who's still 100% faculty member and decided that they're also raising capital, which generally isn't a good idea because that's a full-time job. So we kind of have these like initial filters, and then I turn it over to someone more qualified to me to sort of look at the real investment potential. I think Bob Crutchfield was on one of the earlier panels, and so we have an investment team that continues that due diligence.
Great, thanks. Chris, I'm going to ask you, move on to a different question for you. With the experience that you have had with deploying in a health system or multiple health systems, what challenges have you faced in scaling your solution across the health system?
Yeah, so the biggest challenge is that every health system, although we kind of want to commoditize them as call it a vendor, every health system is different, right? You have different people, different policies, different backgrounds, different politics, the list goes on, right? So the solution that we implemented at Wellstar is not the same solution that we're implementing at Emory or UCLA or some of these other ones throughout the country. So I think really being hands-on and really understanding the nuances of all of those things is critical to be able to implement successfully. But at the same time, as a vendor or basically a company that's trying to inflict or impart change within, there's only so much you can do, right? You can't be customizing your web interface for every feature request. You can't be updating your device for every surgeon or physician that has a different nuance in how they do their specific techniques. So I think there's a little bit of educational outreach that's involved as well. I think for companies that I've been a part of that have scaled super quick versus ones that have really taken a little bit more time to get up and going, it actually goes back to a lot of what Jesse and Moses say. It's like you need to have a pretty immediate, fast impact. And I'll give an example for what we're doing currently at Huxley. So, for example, if any of you have ever gotten tested or diagnosed for sleep apnea, you know it's a very cumbersome process. It takes over 6 months. 80% of people are undiagnosed because they don't want to go through it. So we started at Wellstar about 7 months ago. We showed immediately that we're able to reduce that time down to well under 14 days, as little as 10. We're able to show that patient fallout is well under 7%, approaching 5%. That's about a 20 basis point improvement from where they were before, which means more revenue capture, but also means that you get more patients on the therapy faster. And then finally, the patient satisfaction scores that we demonstrated, about 4.7, 4.8 out of 5 stars. Previously, they're at a 2.5 to 3 star patient satisfaction. So I think like the ability to come up with truly impactful innovation, and at the same time you're able to show some KPIs that are relevant really quickly, I think that's kind of what you need. And additionally, just working with the health system as a true partner.
Great, thank you. Okay, so Jesse, again, because you wear so many different hats, what hurdles do you see in terms of commercializing healthcare or just IP out of the university that might add to the challenge that we face here? Yeah,
I think we talked a little bit about funding earlier, and that's certainly a challenge. Is sort of particularly when it comes to shifting from a mindset that you're going to be able to use an NIH grant to get yourself all the way, right? An NIH grant is hypothesis-driven. It's meant to answer a series of questions. It's not really meant to do product development in milestone stage sort of targeted development. So that's one of the hurdles that we have, is sort of shifting that mindset and then figuring out how to fund those milestone stage development steps. Leadership is a big thing for us. At the end of the day, a company, to be a real and true company, needs to have effective leadership, and it needs to have someone who's dedicated to running that business. And I think that that's an area that as an academic institution, that we're working to put more resources in. How do we start to find fractional operators for some of these companies and starting to pull together those resources? That way there can be a dedicated team to lead the product development and take it out of the hands of the busy clinicians and faculty members who have a day job that they're also trying to do, such that the likelihood of success is longer. I think Chris is going to weigh in on that.
No, I completely agree. I think a lot of people, like the narrative in academia, it's like, hey, we need to do a better job translating, research into impactful technologies. People kind of focus on the research. It's like you said, they focus on the IP. They focus on very tangible things that probably provide some monetary value to the university or the institution. But at the end of the day, I completely agree with you. It comes down to leadership, right? It's the soft skills. It's the professor that's willing to take time off from his academic duties to figure out the nuances of the customer problem, to figure out using PhD level research, like how does my research actually work to impact that problem, to then be able to build a team behind him or her to create value. And that's leadership. That's not something that I think a lot of universities do well specific to entrepreneurship. Obviously, there's leadership programs at every academic center, but the type of leadership that you need to build a business and entrepreneurship is very different versus building a lab or applying for grants and getting a bunch of publications out. And kind of what you said earlier, Jesse, I don't recall if it was out here or in the green room, it's like aligning incentives to enable that, right? It's important that if you're translating research out of academia or other areas, that there's some financial or career incentive to do that.
Great, thank you so much. And I think it kind of starts to get into the next question around how can startups, universities, and health systems better collaborate to accelerate the innovation process? Just open to anybody that wants to answer, that'd be great.
I could say from, the health system perspective where we have noticed that when there are either entrepreneurs or academics who are trying to innovate within healthcare but aren't familiar with the workflows, the end users, and the processes, we kind of have an opportunity to Jesse's point, is to kind of open up our doors and collaborate better and kind of expose some health tech entrepreneurs and folks who haven't had that exposure to workflows and patient-facing care, to what our processes and workflows look like, because those sort of key nuances are really important when you're kind of coming up with a product that is going to be used within a health system. So really opening up our doors to folks to get them familiar with the process is probably something from a low-hanging fruit perspective that we can do for the ecosystem.
Totally agree, thanks. Anybody else?
I don't want to sound like a broken record, but it's kind of what you said. It's like leadership, right? It's like, and maybe the way I would say it differently is entrepreneurs. So I think a lot of people, we kind of touched on this earlier about, deal flow or funding in the Southeast to do innovation. There's actually a really good article on this on Forbes earlier this year. It had to deal with unicorn, $1 billion and up type of companies, and there's an experiment that happened during COVID where Miami, they did a bunch of tax credits and lured a bunch of venture capital firms like Andreessen Horowitz to the area. They actually shut down their shop in Miami. Even though they brought a bunch of money to the area, the entrepreneurs didn't want to follow. So I think it's more, and that's because of leadership. It's because entrepreneurs have to be the leaders that instill that change, and there's no such thing as a unicorn funder or venture fund or that type of thing, or health system. They're only unicorn entrepreneurs. So I think instilling a culture instead of backed on funding and research, but a culture that instills entrepreneurship and allowing leaders to take a risk to do something that's probably outside their comfort zone. I think that's probably what it's going to take.
Yeah, and just real quick, I'd like to add, I think that one of the things that I see in my role is that none of these organizations can be completely effective in driving innovation without the support and the engagement with an ecosystem. So, community and ecosystem and willingness to engage facilitates the dialogue. It elevates awareness, and it really develops the understanding of what can be. So I just didn't want to miss that fact. It's entrepreneurs can't survive without community and ecosystem. Health systems, universities all play a vital role in developing that ecosystem, and the more they engage, I think the better off we'll be.
100% agree. I think it's like a virtuous feedback loop without getting too technical.
Yeah. Okay, so we're going to move on to a new topic, something that you've heard a lot about today. AI is exponentially accelerating the pace at which technology can be developed. Healthcare has traditionally been, let's say, cautious in the pace at which they accept or adopt new technology. So the question is how is your organization adapting to an AI-forward paradigm that includes the acceleration of the ability to accelerate technology delivery?
I can start. So we're doing it via a variety of ways. So one, about 2 years ago, maybe year and a half ago, our institution adopted an AI strategic plan, and that was done at the encouragement of our president. So we sort of laid out a roadmap for what success in the space would look like, and it really tackled everything from infrastructure to our clinical use cases. So that's one, and we've seen a lot of progress in terms of our adoption of technology, particularly as it pertains to clinical decision support tools, right? And support is being the key word there, right? We're not handing off decision making, but how can we start to reduce the mental load for our care providers, as an example. So that was one, the strategic plan. We stood up an AI governance committee that looks at all vendor requests that are coming in that have an AI underpinning, is two, to actually do the, sort of like the trust but verify. We want to make sure that the models that they have been validated in are robust enough to really reflect our patient population, because as everyone probably in this room knows, your inboxes are probably full of vendor emails that just use the word AI. But you really have to start asking a lot of questions, right, to really understand how validated that AI model is and what it's really doing. So we have an AI governance committee. And so I think that's kind of worked for us. And then the last thing is we actually just hired a chief artificial intelligence officer for the enterprise as well, and she'll start November 3rd. And her job will be to coordinate all of the AI activities across the university and within the health system to make sure that we're maximizing utility both from a deployment standpoint, but also looking at our internal build capabilities in parallel.
Yeah, I'd say I think our health system is very similar to yours in that we also have a sort of AI governance committee. I think we call it a center of excellence, where we also hired key leadership to oversee our AI function, and sort of we kind of treat AI like we would any other clinical intervention. It goes through privacy, it goes through security, it goes through bias checks, and then we only deploy tools that integrate into real workflows with very clear oversight. And so, I think for us, that dedication comes with both people resources as well as digital resources.
So Moses, you shared an example of a simple application of AI when we first started around transcription and SOAP notes and things like that. How far do you see, let's say in the next year, how far do you see the adoption of AI and in what application? So you started with something simple. The other end of the spectrum is clinical decision making and diagnosing and things and all of that. So where do you see the balance in the coming year?
Yeah, I think very similar to sort of Jesse. I think the sort of AI has become this catch-all phrase where there's some sort of parsing that's necessary to understand, well, is this big data? Is this kind of a predictive analytics thing? Or is this actually sort of AI sort of interventions? But to your point, I think we really did start with some low-hanging fruit opportunities in terms of like ambient listening. But I think some of the more advanced iterations kind of include integrating AI into some of the diagnosis that we have. We have a company called it escaped me. It'll come to me in a second. But from a radiology and imaging perspective, helping us like parse through thousands and thousands of images and assist our radiologists. And to, I think the other end of the spectrum is us actually creating within hiring a data science team and supporting our AI governance team to build our own sort of AI application so that we can commercialize our own data and start ingesting it. So I think that's the most kind of advanced iteration of what it might look like.
Makes sense. Jesse, can you see how far we're going to push the bubble for you all?
I think it's going to be everywhere. I think we're in the back office administrative functions. We assume that we'll be buying a lot of that stuff. Revenue cycles ripe for automation. We're already deploying it in some of our clinical trial areas to sort of automate those routine tasks. So you kind of look at which type of AI are we talking about. ChatGPT and the language processing gets a lot of press now, but RPM technology has been out there for quite a while. Image processing has been, kind of leading the way, particularly in dentistry, right? And so we're already seeing good uptake in those areas, and I think we're going to continue to see more as we start to look at sort of the unstructured data fields and the things that we can do with note-taking and things like that. But I would say MUSC is leaning hard into this space across all of the areas.
Chris, tell us a little bit about where AI fits in your product roadmap.
Yeah, so I think in terms of improving inefficiencies and I think you've all heard about that. I'll kind of talk a little bit about how it impacts our sales cycle. So yes, there is AI in our product roadmap, specifically enabling us to auto-detect and or help physicians auto-diagnose diseases, but it slows down the procurement process like crazy. So we actually don't actively promote it.
Point.
We talk more about rules-based type algorithms.
Back to the old terminology.
How these were, trained and developed, but then validated independently and closed off. So I think, yes, it's great on your side, on the healthcare side, but on the vendor side, trying to get in, we tried to actually avoid over-promoting it, but I think everyone's right. It's definitely going to change how we deliver healthcare for the better, for sure, if done correctly.
Great. Any other thoughts at this point? Okay, so what is your advice to startup vendors in regard to health systems' appetite for AI? And Chris just mentioned his approach to kind of presenting AI in maybe more traditional language and things like that. Do you guys have advice for startups? There are so many out there that are just completely on the AI bandwagon, right? And they need. I think there's definitely some advice you guys can provide in terms of how should they be approaching you with AI forward solutions.
I think, as you just heard, don't just put it in the subject of your email. There's going to need to be a little bit more description, and I think as health systems are getting savvier, we're starting to ask more questions, and it does, just to be clear, I think Chris is right. Anytime you add a layer of governance process into anything that's already within a pretty bureaucratic setting, whether you're talking about the university or a health system, it's going to slow it down a little bit. So I think that needs to be a realistic expectation, is that it does add, I think rightfully, a little bit more vetting. You're going to need to be pretty transparent about, as I said earlier, the models at which you've been validated on. And two, I think that the questions that we always ask is, how does that fit our own patient demographic, right? Is this really going to work for ours? And I can give, this is a true example, but I think pretty illustrative. We had a company, it was actually Norwegian based, I think Norway. They came in and they had an AI-based technology that was going to help do bilirubin reads on newborns after the 3 days, right? And this is actually a real, so I was like, okay, this is kind of going to tell if they're jaundiced or not. And to Moses' earlier point, I went to our PEDS team and said, is this a real and true problem? And they said, yes, because if the read is needed on a Sunday, they sometimes have to go to our ED to get checked, right? And we don't want to send new moms and their babies to the ED. And so all thumbs were like pointing up like, yes, it's a real problem. Yes, we could use this. And then we asked what the model it had been validated in, and it only worked on the 2 lightest skin tones. And so that doesn't work, right? Like, we cannot roll out a technology across our state that only works if you have skin color like that is as fair as mine, right? And so then it just became an immediate no. And so I think if you're a technology vendor, you need to know that you need to be able to work across the full spectrum of patients that we're going to have and sort of really meet the needs of the demographic of the population that you're trying to get into.
Yeah, I completely agree with Jesse. So the FDA has actually done a really good job with this, in my opinion, at least when it relates to our technology. So and I'll give a pretty more technical example. So the FDA required us to validate our AI algorithms, making sure that the sites that we used to develop the algorithms were not the same sites that used to validate, to make sure that the patient demographic was representative of what you would see throughout the United States. So we had a very diverse patient demographic. We conducted one of the largest FDA clinical studies for our device and algorithms because of that, because we used AI. I think the main thing, so I think it's absolutely important to be able to validate and show that it can work on the demographic that you're using. I think when it comes from vendor to healthcare provider relationship, being able to talk about that openly and transparently and walking them through that, because a lot of times, and you mentioned this, when you do this extra review, a lot of times it is outsourced. A lot of times these people don't have clinical backgrounds or understand the nuances of how do you design and validate and power a clinical validation study. So I think it's coming up with that talk track and being able to get them on the same page.
Great.
Yeah, I think maybe I just to highlight what Jesse said in terms of really picking your wins. I think once you get into diagnosing and clinical decision support, I think the level of scrutiny and validation that's kind of necessary for those AI solutions is a bit sort of higher. So if possible, some of these use cases around prior authorization, back office, revenue cycle management, and things like that, where really sort of demonstrated kind of common sense wins that have immediate impact on the balance sheet, I think, are really good places to start. But at the same time, again, not to sound like a broken record, but I mean, picking a pain point that has real urgency and emergency sort of within the health system. I forget the term. Is this a vitamin or a vaccine sort of thing, right? Is this a nice to have versus a must have? And so focusing on things like that from your AI strategy is key.
Awesome. Thank you, guys. So all of this conversation, not only are we talking about how innovation is changing the face of healthcare delivery, there's an undercurrent of a theme of the pace at which change is occurring. So it leads to the question of, what are your thoughts in terms of whether or not policies and regulation are keeping up with the pace of healthcare innovation?
I think it's lagging a little bit.
Okay.
I mean, but the pace has been so rapid, right?
Right.
I mean, we're talking a lot about AI, but I think just the pace of technology, just in general, is really, really fast at the moment, and it might be an unfair expectation that it's going to be that policy can lead it, right? So,
Is that a risk to the organizations being able to keep up with the demand?
Maybe, but I also think that healthcare, and by nature, is we're kind of risk averse. And so we have a lot of measures, at least in my organization, to sort of do a lot of vetting and a lot of question asking. Right. So, not solely relying upon firm policy written, but also due diligence that we're doing ourselves.
Sure. Chris? Oh, good.
Yeah, I would agree with that. I think good clinical practices or good study design, right? It requires you to validate. It requires you, yes, you have these, for lack of a better term, black box type things that are out there. It's like trust but verified, like you said before. So I think, going about it with the right clinical mindset of, all right, this could be a game changer, but how do we validate that? And how do we validate that pragmatically? I think that's going to be an important part until the regulation catches up.
So you have to, definitely have to put in the work and the rigor and structure to ensure that clinical practices are still followed, quality management, all that. And that's not just for regulatory purposes, it's for the benefit, ultimately, of the patients.
100%.
Yeah.
No, I think that's right. To Jesse's point, I think for better or worse, I think the culture inside of a health system is almost, several structures have been put in place to make sure that anything that is patient-facing is clinically validated, has been rigorously tested, and has been kind of approved. And I think the downside of that is that we may be lagging in terms of adopting new technology and sort of different things like that. But yeah, building the plane while it's in the air is kind of the way of life within the whole.
Right. And just again, I see a lot of founders that come from outside healthcare, especially with the new technologies. They come in with ambitious strategies or products that they think will help solve the world's healthcare problems. There's, one thing they have to remember is that the majority of the organizations that they're selling to are and their solutions, in fact, truly could be life or death situations that they're dealing with. So it may be easier to get in another industry. And just real quick, I will say, when I see startup companies that have an enterprise solution or something that is targeting healthcare as their first market, first thing I do as a coach is I look at whether or not there's applicability across other industries. A lot of times they know that, but if that's the case, I do provide guidance in regard to considering gaining market presence and traction and validating your product in an industry that's much less regulated than healthcare. So it's a challenge because healthcare is intentionally difficult to penetrate. And so, I do think that there's opportunities for regulation and policy to accelerate, but it's gotta be done with intention and structure.
No, I agree with that, Greg. I think what I tell entrepreneurs that want to get into digital health, call it healthcare type space, is that there are definitely easier ways to make money, for lack of a better phrase, but which means that it has to be mission and vision purpose, right? You have to, like when I look on my career and kind of everything I've done to get to this point, it's because there's no higher reward, there's no higher calling than having an impact on lives, right? And be able to improve the livelihood of people that you care about and people that you don't even know. And, if you decide in terms of like practicing medicine, it's like a physician, a healthcare provider can only do so much, but a new technology, new innovation that's able to get 10x out of that system or that provider, that makes a meaningful difference. There's no, in my opinion, higher calling.
Great, thanks. Okay, so I want to move into just kind of looking towards the future of healthcare delivery. What innovations or trends are you all individually most excited about in the next 3 to 5 years?
We talked about this in the green room. I'm not going to say a digital thing. I'm actually, I'm most excited about immunotherapy and the role of genomics actually in precision medicine. But I think immunotherapy is really, really exciting.
Great, thank you.
Yeah, I think for me, just keeping with the AI theme, choosing sort of a low-hanging fruit from a patient-facing consumer perspective is conversational AI via wearables for sort of at-home care. So, devices like wristbands or wearables that kind of let patients talk to them or interact with them naturally to report their symptoms, to get reminders, or to kind of trigger interventions. So that would be blending wearables, voice, and AI to shift sort of monitoring to daily life. And I think why I chose that, number one, is just we have this huge, high unmet need from an aging population perspective, people with chronic conditions and their caregivers under deep stress and having these pain points around loneliness, safety, follow-ups, oversight, and things like that. And so, conversational AI via wearables as an opportunity for better oversight.
So before we move on to Chris, do you see in the next 3 to 5 years it getting to a point where AI is actually doing all those things, everything from diagnosis to developing treatment plans to follow-ups and from a clinical perspective as well? Or is there always going to be a human component, or for how long will there be a human component?
I think the human component will be there for a while. I think the word diagnosis is tricky from a regulatory and an FDA perspective, but in terms of informing clinical decision-making and clinical decision support, I think that's the sort of easiest on-ramp for wearables and AI to support diagnosis.
Great. Chris, 3 to 5 years, what do you see?
Yeah, I think I'll follow Mosa's lead, but probably get a little bit more granular. I think the direct-to-patient care is probably the most exciting for me, and I think it's going to be the most impactful when we think about the industry as a whole. To get more tactical, I know we talked a lot about AI and software and how that can help with that. I don't think that's a big chunk of the pie. It's a big pillar, but I don't think it's the only one. Obviously, you mentioned diagnoses at the home setting. When we think about that, it's tough to just rely on software. You need sophisticated hardware and sensors. The Apple Watch, even though it's FDA cleared for screening a lot of diseases, if anyone has actually worn it and gone through that process, you still have to go to the healthcare provider to get a diagnostic device, and then you still have to figure out how you get pre-auth on that. You still have to figure out, once I get this diagnosis, where do I go for therapy? How do I do the therapy? Who's the best provider for this therapy? How do I get to the right referral pathway and get the right procedure or therapy done? I think that's going to take a multifaceted, multi-innovation type approach, right? That requires sophisticated hardware, not only just hardware, but probably new therapeutics or new designs of current devices. That's going to require software, not only just AI, but probably other types of cloud connectedness and being able to streamline workflows. And finally, it's this whole service component. At the end of the day, you still need a provider or someone to be able to provide that care. You still need to figure out, how do I move this patient through the funnel in a seamless type manner and get them on therapy or get them to the procedure that's required. So kind of as an entrepreneur and kind of what we're doing at Huxley, that's kind of what we focus on. It's kind of all three to be able to streamline that. And I think that's really the only way, that interdisciplinary and call it technology type approach, to be able to achieve that outcome.
Great, thanks. And since I'm here and we have time, I am going to share my 2 cents as well. I do think that I'm really excited about where we're headed in terms of personalized care delivery. Spent my whole career dealing with pop health and making gross assumptions about populations. The fact that technology is enabling us to actually provide curated, personalized care alternatives, allowing individuals to actually be proactive in their own care, but being able to reasonably collaborate with the whole healthcare continuum along those lines, I think is super exciting and long overdue. Okay, so our parting question before we go to Q&A, from your all's perspective, what must change to truly unlock the potential of innovation in our industry?
I'd say for me, keep it simple, is that we have to continue to move to value-based care.
Okay.
And I think even today, we're still seeing some of the most effective and smartest technologies that are improving efficiency, they're reducing utilization, but they still kind of struggle to get traction because, to someone's point around incentives have to continue to change to being compensated and reimbursed for value versus fee for service.
Great, thanks.
I agree, and I'll supplement with we need to really start to unlock the power of the data that we have in order to do that.
Yeah, I think we all touched upon this, but I'll take a step back. So when you look at any other service industry in terms of what drives change or innovation in those markets, it's the end users, it's the customer, right? So if you were to open up a new restaurant and you kind of had, bad service, bad dishes, bad chefs, bad technology stacks, like you probably wouldn't be in business that long. Healthcare is a little bit different because there isn't that transparency to the patient. The patient doesn't really control their journey. They don't control how they pay or how costs get split up. So I think, Greg, what you mentioned too, this whole shift focusing on the patient to empowering the patient with information and guidance and technologies to guide their healthcare pathway, I think that's what it'll take to really drive true innovation in healthcare. And that's more than just technology. That's probably changes in regulation. That's paradigm shift. That's probably, I think Sam Altman said, like, the next company that works on AI is probably not going to be that valuable. It's the company that leverages AI to do the next big thing. It's going to be that in healthcare, right? It's like, how do I use AI to get, a novice patient who wants to make a change but doesn't have the information or analysis to be able to do it? It's like, that's probably where AI can help, and then being able to pair it with unique devices and therapies and services to help that patient along their journey, having price transparency to that patient so they could decide how to finance it through either insurance or maybe some unique fintech type way to finance healthcare. I think that's what's going to take, because at the end of the day, I think we do need an external driving force to institute change, and I think it has to come from patient.
Great. Well, thank you, panelists. Really appreciate it. This is the one session where we're going to open up to Q&A. So if you have your questions, feel free to ask. Is there somebody that has a mic that can pass around, or? I'll be happy to do that as well. So any questions? Sorry, it's hard to see. I'm going to step down, actually, so I can see if there's any questions.
Looks like there's one, a couple.
Yeah, go ahead.
Do you want to?
Well, I'd be interested to learn more about that. I think the iterations that I've seen are some form of integrating into the EMR and doing some level of risk or predictive analytics and around a patient that we haven't identified as acute, and providing some intervention for that patient before they become acute. And so I'd be interested in what you're mentioning, because that's a different take on it.
Yeah, I can give you our observations and then maybe one approach that we're looking at. So we have a tool that we rolled out in our ED for chest pain. So that's the sort of the example that I use. And our utilization rate is actually really bad when we look at it. And we talked to the ED chair, and she's like, look, I already know what I want to do before I go in the room. So it's hard. And she's like, and I want our trainees to have to figure it out on their own. And so that adoption has been a little bit tricky for us to try to figure out how to incentivize utilization of a tool that's there just to help, standardize our pathways. We find that in our Charleston facility, which is our primary academic center. So it's our, our tertiary, level 4 trauma center. Out in our community hospital, we rolled it out into our smallest rural hospital. Much better utilization by our practicing ED physicians out there because they're really interested in standardizing care and maybe not as up to date on what current practice guidelines say the next step should be. And so we're sort of working through what that looks like now. How do we do the change management that's appropriate? And then for the company, because it's pretty early stage, they're really interested in demonstrating value so that they can roll out to our other 16 sites. And our primary rollout was Charleston. So we're struggling through that, if I'm being candid. But to your point, on the students, one of the things that we are looking at is piloting for education. So what is the educational outcome if they use a tool versus if they don't? Can we see a difference in how they perform on a variety of metrics, like at the end of it? So more to come on that. But that's one of the things that we're thinking about is, like, how can we actually turn this into an academic exercise, too, as we're thinking about utilization.
Any other questions? Here. I'm going to bring this. Go ahead. No, you go. I'm going to take the mic over there.
Well, I'll go a step before AI. How do we get off fax machines, right? So, right.
Yeah.
Right. Oh, I mean, I'm almost embarrassed to say that we're still implementing solutions that are transitioning from fax machines to coordinating care via email and secure messaging and different things like that. And I'm looking at my wife, and she's a cardiologist, and she tells me these stories of getting 200-page reports via fax, and she has to parse through it for the patient's data. And I'm like, oh, so you're not using email for that? I didn't know that. So long way to go for us, but I think AI is the goal, but we're really starting with just care coordination in the simplest form.
I think nurses are the largest workforce within a healthcare system, and so they have to be top of mind too as we think about max. And it's a declining workforce, right? So we need to think about, you're not forgotten, I would say.
Hey guys, one, thank you for the panel. Really insightful. Good to hear the perspectives around us, and maybe not a question, but just a deeper perspective that I'm really looking for, because I think what you highlighted today was sort of this paradox of, we want these health technologies to be adopted by, be it the clinicians or physicians or patients and caregivers. And Jesse, you said it, like, we need to make sure we show up with evidence that it works in your demographic. But I think the paradox that exists is basically no pilot, no data, no data, no pilot. And that's a really interesting thing to solve for us as innovators, cash-strapped, different milestones, building a business. But the perspective I'm interested in is, how do you think about, how do we solve that paradox when we can't show up with the data that you need, but yet we can't afford it, and then when we can't afford it, we might not have the diversity of the population that represents your demographic?
I think that comes back to what I was saying at the beginning about health systems learning to be a little bit more flexible. And it's a little bit of a two-way street, but like candidly, I think if you're an early stage company that's not coming in being able to fully demonstrate effectiveness, then you also can't come in and ask us to spend $500,000 integrating your system, right? And so there has to be a level of understanding on the startup company side about how much the technology is going to be valued by the health system if it's not demonstrated. And then on our side, we can't treat you like a Medtronic and expect you to come in full scale. And so the conversation really needs to be on the earlier end about what's the value of a pilot, what can be the endpoints of a pilot to know that it's going to be successful, that gets an early stage company the data that they need, but also demonstrates the value for us in a cost-effective way. Because, we always say, like, if it's $500,000 to pilot, we're not pulling it back out, right? And so we have to figure out a way to move it forward together. But that's where I think health systems need to be a little bit more nimble in terms of how we think about supporting earlier stage technology development, such that we can help you get to where you need and derive benefit on our side should it prove effective, right? But it has to be a two-way street with good transparency and partnership.
So I say, something I've seen work and kind of the increasingly sort of effective motion is kind of starting with the direct-to-consumer sort of perspective. I'll tell you, before working at a health system, I was a CFO for a startup that was basically an AI chatbot for behavioral health. And so we literally sold ads on Facebook, and we got 20 to 30,000 sort of direct-to-consumer sort of customers that way, and started generating data and outcomes there. And then when we went to sell to the Blues and to other health systems, we said, hey, listen, we have this outcomes data for a population that you actually don't have access to. And that was sort of our foot in the door to get the additional pilot and to kind of go from there. But point taken that often it's a D2C to a B2B2C sort of motion, and to your point around long sales cycles and costly capital, all that goes into it.
Yeah, I know we only have 30 seconds left, so this is something that I've done ever since I was a PhD student. So it's impossible to invent the future of medicine without, if there's no budget for it, by definition, you can't invent it, right? So there's almost like incremental versus true innovation. That's where academic research, I think, comes in play. That's something I've done. More than happy to discuss that after this.
All right, with that, we are officially exactly out of time. So thank you all very much for coming. Really appreciate it.